साथ साथ ले हाथ हाथ चले राह नहीं एक सोच नहीं सब आओ साथ साथ ले हाथ हाथ चले राह नहीं एक सोच नहीं सब आओ विश्वास है मन में यही देखेंगे हम एक सुबह नई
This is Ankit, whose life is but an endless wait. His wait is for curing his condition of bone TB, with which he is afflicted. Ankit had TB when he was 3 years old, which filled his childhood with pain and replaced toys with medicine. So, at an age when most children are playing with toys, Ankit had to endure a 9-month anti-TB treatment course. But that was not the end of his poignant story. The disease showed up again.
सही होने के बाद ही फिर नानी वहाँ गया तो इसको ये गांठ हो गया ये तब यहाँ लेके आए वहाँ से हम तो इसका इलाज यहाँ चालू किया वो तो पढ़ाई तो बंद हो गया था बीच में जब दवाई चालू हुआ तो पढ़ाई वहाँ बंद हो गया तो वहाँ से लेके आए 2 महीना बैठे रह गया उसके बाद में इसका इलाज पढ़ाई चालू करवाया ट्यूशन लगवा दिए हम और वो यहीं पे
Akshay and Pankaj have a lot in common. It's not just that they are brothers and constant companions. They are both afflicted with the same disease, XDR-TB. Their father is a vegetable vendor in a small town in Punjab. It's difficult to make ends meet.
जैसे हमारा 150 पौने 200 रुपये रोज़ की आमदन है उसमें हम घर का खर्चा करेंगे। अब बच्चों की मेडिसिन छोटे वाले की 5,000 रुपये, बड़ी वाले की 7,000 रुपये, खाली दवाइयों का खर्चा 12-13 हज़ार रुपये लगभग 1 महीने का पड़ता है। इससे हम खर्चा नहीं उठा सकते, हम इसी वजह बड़े परेशान हैं।
अगर लड़कों में ऐसी प्रॉब्लम आ गई है तो वो सोचेंगे कि इनकी बेटियों में भी होगी। यही है ना कि 2 लड़के ऐसे हैं तो इनकी बेटियों में भी ऐसी मुश्किल होगी या तो पेरेंट्स में ऐसी होगी तो वो ज़्यादा इशू हो जाएंगे। अगर लड़कियां ठीक हैं तो कल को लड़कियों की ज़िंदगी में रुकावट आ सकती है ना।
जो इनको पढ़ाते थे अध्यापिका इनसे घृणा करने लगी कि मुंह पे गिल्टी हो गई थी, अब मुंह पे रुमाल बांध के तो ये जा नहीं सकता था स्कूल। इससे हमने बच्चे फिर घृणा करते, रोज़ आके स्कूल से रोता था। इससे हमने बच्चे को बड़े वाले को मतलब स्कूल में जाने से मना कर दिया। अब बड़ा वाला तो स्कूल जा नहीं रहा, जिस स्कूल में पढ़ते तो वहाँ जा नहीं रहा। छोटे वाले को स्कूल में डाल दिया है तो उसको पता नहीं किसी ने चुगली कर दी है आस पड़ोस में से, बस उस छोटे वाले को भी स्कूल से निकाल दिया गया है।
मैं तो यही बच्चों को बताती हूँ, आज वक्त आया तुम्हारे दुखों का, कल सुख का भी आ जाएगा। अगर भगवान ने अंधेरा दिया है तो रोशनी भी ज़रूर दे देगा।
It may seem like a bad dream, but this is the reality innocent children are having to face for no fault of theirs. There is a global resurgence of TB that includes India, where around 750 people die of TB every day. A significant number of the cases of TB include children, and the estimates vary between 5 to 20%. Despite having proper guidelines for management of pediatric TB and pediatric MDR-TB under DOTS, that is, Directly Observed Treatment Short Course, and DOTS Plus respectively, children are going untreated, as many parents end up seeking treatment in the private sector. Many times, the parents and private doctors repeatedly change or stop treatment midway, either because they seek quick results if the symptoms take a long time to subside or feel it is cured.
There's a rush on the part of the clinician as well as on the part of parents. Tuberculosis is a chronic disease. It follows its own course. Once we are sure we have diagnosed tuberculosis and we have started the treatment, we need to understand that it takes minimum 1 to 2 months for the fever and cough to come down. So one should not start and keep on repeatedly changing the drugs. The drugs, they are toxic, but they take their own time, and it's not a regimen which you can stop in say a month or 2 months. It needs to be given for minimum 6 months.
That is why the regimen needs to be given under direct observation, where patients actually swallow the pills under supervision of a DOTS provider. Lack of this awareness is pushing lakhs of such children towards a doomed future. Here, at the government-run DOTS Center at Mehroli in South Delhi, children who are being treated had first been taken to a local doctor and came here only after a few months of being treated with anti-tubercular drugs, including reserved second-line drugs.
बचपन से रहता था, ये तो होते ही नर्सरी में ही दे दिया था। उसके बाद ये ठीक नहीं रहा, दवाई वाई ऐसे ही है बस ये। फिर गांठें निकल गई, फिर इसको ऐसे मतलब प्राइवेट भी दवाई दिलाई, आराम नहीं हुआ। फिर मैं सीधा ना इसको टीवी में लेकर गई थी, तो जब वहाँ पे बताई कि इसको ना टीवी की गांठ है, तब उन्होंने मुझे यहाँ पे भेजा।
बच्चे ने लोचा था, किसी बच्चे ने खेलते खेलते लोच दिया था, तो सूज गया था हल्का सा। फिर हमने अगले दिन देखा तो एकदम बड़ा सा गांठ सा बन गया था। फिर ऐसे आस पड़ोस के लोगों ने बोला इसके गांगन वगैरह निकला हुआ है, इसके घरेलू उपाय भी बताया उन्होंने, वो कराया मैंने। फिर उसके बाद उधर इधर हॉस्पिटल में सब जगह दिखाया तो सब ने यही का नाम दिया, इसी हॉस्पिटल का नाम दिया, टीवी हॉस्पिटल में दिखाओ बोला। फिर यहाँ दिखाने के बाद काफ़ी इसको आराम है पहले से।
इसको बुखार आता था, टाइफाइड बनता था, और फिर हमने दिखाया, तब इधर इधर को तो बहुत दिखाया था। फिर किसी ने सलाह दी थी इसकी मैडम ने कि इसे वहाँ दिखाओ टीबी हॉस्पिटल में। हमने वहाँ दिखाया था, 2 महीने ये एडमिट रहा था वहाँ से फिर यहाँ भेजा था।
Ali Hassan is only 1 year old, but he has contracted TB in his abdomen. He has been on medication since September 2011 and has been responding well. If children are brought under DOTS as soon as they are diagnosed with TB, they can get cured in 6 months, as with most TB cases. But the truth is that increasingly many of the children are developing drug resistance because of non-compliance.
This leads on to the problem of what we are now facing as MDR and XDR. Because of these frequent changes in the drug dosaging as well as the different drug combinations used, we have proper DOTS plus guidelines available for children. We have divided children in 2 weight bands. Less than 15 kg we do not give the medicines, 15 to 25 and 25 to 45 kg. We have 2 weight bands, and we are providing the full course of 2 years of MDR management free to the children throughout the country, and the program is being implemented step by step.
A big problem in the management of childhood TB is of diagnosis. The sputum test used for adults is also used for children. But sometimes small children are unable to produce sputum on demand for testing. Hence, the smear and culture tests have low sensitivity among younger children. So, diagnosis has always remained a challenge.
So very often it's based on clinical diagnosis, based on X-ray, based on other investigations. So there's a great need for a new rapid as well as a sensitive diagnostic test that can be used not just on sputum but on other body specimens that you get from children, something that works on saliva or something that works on urine or even on blood would be a major advance for childhood TB diagnosis, and this is something that researchers are working on.
Diagnosis of TB among children is difficult also because of the paucibacillary nature of the disease. This means that there are very few bacilli present in children. Therefore, a large proportion of the cases go unrecognized. Though in India, things are a little different. Each year, globally, every 5 minutes, a child dies from this disease in developing countries. It was a forgotten illness which has reached gigantic proportions now and thus needs to be nipped in the bud. India's revised National TB Control Program, or RNTCP, has a provision of contact tracing in children to detect TB among those in contact with an adult TB patient.
So we really need to go and do what's called contact tracing. Go into the community, the household of all the adult TB patients, find out the children who are at risk, screen them, treat them if they are found to have TB. But if they don't have TB, then we have something called chemoprophylaxis, where you give a 6-month course of a single drug, isoniazid, to these children, and that's been shown to be quite effective in preventing them from developing TB.
India has the highest TB burden in the world. Therefore, it is important to focus on development of more effective drugs, which would shorten the anti-TB treatment drug regime for children. Research and development in this direction is going on in the entire world, including India.
Pediatric TB has always been in focus, but the only question was earlier that there were no formulations available for pediatric TB patients. We actively encouraged all pharmaceutical manufacturers and are still encouraging them to come out with specific formulation, maybe liquid formulation, maybe suspensions for pediatric TB patients. As of now, we have drugs which are available as tablets in different weight bands, but we are encouraging the industry to innovate and come out with specific oral and suspensions for pediatric TB patients.
There are also as many as 10 new vaccines for children under trial throughout the world. Most of these trials are taking place in Africa. It is important for India to join the trials as well, so that once the vaccines are successful in trials, they can be quickly brought into use. Presently, the BCG vaccine given to newborn children gives protection against disseminated and dangerous forms of TB only for a few years. But after attaining the age of 5 to 10 years, a child again becomes vulnerable to the disease.
There are also 1 or 2 Indian groups working on a TB vaccine. So I think India needs to focus its R&D efforts more to take these early vaccines which are being developed in India to later stages of testing, but also to get involved in international multicentric clinical trials of TB vaccines, so that if any of these are shown to be effective, they can be quickly registered and used for the children in India.
It is also important to adopt a more holistic approach towards disease, more so in the case of children, and pay attention to nutrition. Almost 48% of the children in India below 5 years are chronically malnourished. The association between TB and malnutrition has long been known. TB makes malnutrition worse, and malnutrition weakens immunity, thereby increasing the likelihood that latent TB will develop into active disease. Certain studies suggest that improving the nutritional status of the child can prevent the severe forms of TB, MDR and XDR. But TB is no longer a disease linked to poverty. It can be transmitted through one fleeting contact at a crowded marketplace, or if a person's immunity is low, the latent bacteria which is present in every human body can become active.
कभी आज तक हमने सोचा ही नहीं कि हमारे यहाँ ऐसा भी काम हो सकता है। ना हमारे आस पड़ोस में कोई टीवी वाला ही नहीं बनता, बस एक हमारे घर में स्टार्ट हुआ है ये काम। किसी को भी आ सकता है कभी भी, कितनी भी सफाई हो चाहे कितनी भी गंद हो।
Children are the future of our country. Not only that, they are the future carriers of any disease which is a burden on our society. If we make their health our priority, the march of disease can be stopped.
We at Neo Convent School have regular health programs for the students where we create a lot of awareness about various diseases, not only TB, and not only students, also the parents. Because we have realized after so many years that the journal awareness amongst the public, including these students, is too low, even for common ailments.
Such awareness is the need of the hour to minimize the risk factors for children. Because of the alertness, the staff of this school was able to identify a 5-year-old with abdominal TB, who is now on anti-TB treatment at a government hospital. But what really can make a difference is a mass awareness campaign, especially in socially marginalized segments of the population. Children constitute a vulnerable group and have been accorded a special focus in the next 5 years of the RNTC program, which also seeks to achieve universal access for all. Here at Pili Koti in North Delhi, such a community awareness program is underway. It is a regular feature across the capital and goes a long way in sensitizing this community about TB.
कम्युनिटी मीटिंग्स में हम लोग बताते हैं कि इसके सिम्टम्स क्या हैं, इसका इलाज किस तरीके से चलता है, और अगर बच्चों को हो जाती है तो किस तरीके से इलाज उसका चलेगा, कि इसके लक्षण क्या हैं। 2 हफ्ते से खांसी है, शाम को बुखार चढ़ता है, सुबह उतर जाता है, भूख नहीं लगती है, वजन कम हो रहा है, सीने में दर्द है, तो आप बिल्कुल भी देर ना करें और सीधे अपने नज़दीकी स्वास्थ्य केंद्र में जाकर अपना डॉट्स के तहत इलाज कराएं।
It is now time to include child-specific messages in mass media awareness programs, whether they are under the RNTCP or other child-related programs implemented by government and non-government organizations. That is the way forward, along with taking some bold and innovative decisions.
We need to limit the use of second-line drugs. Second-line drugs, they are freely available across the counter in a chemist shop. And this needs to be totally banned, because otherwise we are sitting on a big time bomb. We have already reached a stage of XDR in children, but if we do not limit the use of these second line drugs, we are looking at something like X raised to the power n DR, a totally incurable state.
Basic catch lies in identifying special populations where these vulnerability exists. Many states are innovating, like we have Anganwadi centers throughout India, where children less than 5 years and even more than 5 years, they go and when their mothers are away, they stay there. So that's one catchment area. Another catchment area is the nutritional rehabilitation centers, which many states are having. Madhya Pradesh, in fact, is specifically screening patients in these nutritional rehabilitation centers for tuberculosis, and we encourage other states to follow the examples of Madhya Pradesh.
Children are like a mirror to the TB situation in the community. If you have high rates of TB in children, it shows that you're not doing a good job of diagnosing and treating adults. So in a way, TB in children really reflects a larger problem that we have in the country of a huge burden of tuberculosis.
This is the moment to take this message more seriously. If we are to give our children toys and not pills for a healthy future.